Good afternoon or evening. Welcome to the webinar. I guess, Martin, maybe you can advise us when we can begin. I see we have 108 participants so far. So we'll just give it 1 minute, then we can begin.
Okay, perhaps. Thank you, Dr. Kaka. We had 700 participants who had registered for the webinar. So perhaps we can start as soon as we clock 400 or 300 in the next, we should start by 5:05.
Thank you for those who've joined in. Always interesting to see who's on the call. So if you do get an opportunity, please share your name and the organization I represent in the chat. I think we have a separate tab for Q&A, so just make sure then you don't interchange the two. Have your intro comments in the chat, and then questions in the Q&A tab. Thank you again for joining. We should be beginning in the next minute. So good afternoon, good evening, good morning if you happen to be in the Western Hemisphere. Thank you for taking your time to join this webinar hosted jointly by JLN and the Kenya Healthcare Federation. My name is Dennis Okaka. I represent healthcare providers in the Healthcare Financing Committee of the Kenya Healthcare Federation. And with me is my co-host, Jacob. Jacob.
Good evening, everyone. My name is Jacob Kazungu. I am a health economist. I'm the coordinator of the Joint Learning Network for Universal Health Coverage in Kenya. Happy to be co-hosting this webinar today with Dennis. Over to you, Dennis.
Thank you, Jacob. Kazungu, I think that's the one we prefer. So it's been quite a journey. A lot has happened in the last few months, and you know, the discussions have been heated offline, meaning off, you know, this platform. And from the discussions, you know, there was a gap we were seeing somewhere. And we felt, well, maybe then it's time to just re-educate and reinvigorate the discussions we've been having on the changes in healthcare that we've been seeing in the country. Of course, we know the push towards UHC and the different facets the government is trying to change from primary healthcare to health financing, to, you know, digitizing the ecosystem. And so in line with that, today we have a small panel of experts, if they can allow me to use that term. And I'd want them to introduce themselves before we dive into the discussion. Tell us their names, their organizations, and if they could put, let me just put a twist to it in one word, or just one phrase, their aspirations for healthcare in this country. So just one phrase, a few words, your aspirations for healthcare for the country. So I'll start with Dr. Elizabeth Wangia. Over to you.
Thank you so much, Dr. Okaka, and your co-moderator, Kazungu, and to the participants who have joined the meeting. My name is Dr. Elizabeth Wangia. I'm from the Ministry of Health. I head health financing. My aspiration as one as the ministry and of course as the head of health financing is that citizens access quality healthcare, not just healthcare, quality healthcare at a price that is affordable, basically UHC, but it's good to unbundle UHC and just talk about access to quality services at a cost that is affordable to them. Back to you.
Nice, thank you, Liz, for that. Quality healthcare at a price they can afford. Good, I'll hold you to that, so keep that in mind. Over to you, Stephen.
Yes, good afternoon, everyone. My name is Stephen Kaforo. I work at the Ministry of Health as a health economist, and we have been in this study for some time. And basically, what you're trying to do and to ensure is that we improve the healthcare of the population to attain a population that is productive and that can participate fully in the development of the economy. And we do this at the most efficient way, at the least costs per output. So thank you. Back to you, hosts and members.
Thank you again. Welcome, Stephen. So Stephen and Dr. Elizabeth, I'll call her Liz for the purposes of this, are from the Ministry of Health, and you've heard what they do. So thank you again for taking time to join us. Our third panelist, Moses, over to you.
Dr. Okaka, thank you very much. Much appreciated. My name is Moses Mukua. I work with CHAC. I'm a finance director there. I speak a lot for the faith-based hospitals, and my aspiration, the aspiration of most FBOs is that the rural people that are underprivileged, mostly poor, in very difficult circumstances, are able to get the highest attainable healthcare in those locations without the hindrance of funding or even having to sell their land and completely become poor because they had to pay for bail. I appreciate it to be on the panel. Thank you very much.
Thank you, Moses. And I hope you're seeing a common thread at least starting to come across our panelists. We have the same intentions. That's very important. Everyone wants everyone else to access, Kenyans to access healthcare, and everyone wants the healthcare to be affordable, even the private sector. So maybe we can start from that standpoint. And I'll begin with you, Moses. I know initially I thought Liz would take the firing squad first. Moses, what are your thoughts on what has happened so far? We've had 4 laws enacted last year, which of course now are in a state of, we call it suspended animation, pending a number of changes. But we've had a number of things thrown at the healthcare ecosystem in quick succession, with the intention of switching how we finance, the supply side of, the demand side of healthcare, right? And what are your thoughts from your experience as a private sector representing CHAC? What do you think? What are the intentions of government from your standpoint? And it could be personal, it could be organizational. Do you think we have the right idea? And do you think we could do something better? Moses?
Yeah, thank you very much. I don't envisage that we will start on a perfect place. We've had NHIF, it has been here for a long time. This idea of universal health coverage has been around with us in several governments, actually. I remember Kibaki Ngilu, those days. There was an attempt during Uhuru's time, and we're in this season. I think we have to start. I'm optimistic. I know it's not going to start off perfect, but we can make small incremental steps and perfect healthcare provision in this country and make it available to more people. We can contribute a little bit more. So I'm optimistic. I know that there are a lot of hurdles that we have to overcome at this time. The faith-based community, all the hospitals and the Muslims, the Catholics, and the CHAC facilities are committed to this. We also know the private sector, and because we interact with them, we have the same issues. County governments, all of us are interested to make this work. So whatever it will take, we will do our part. Dennis.
Thank you, and I like that commitment. I hope, yes, we have it as a recording. We'll also share it as a solid commitment we have to the government of the day. And so knowing that commitment, now back to the government side, Liz and Stephen, maybe give us a background of what you had in mind and what you envisage UHC to look like, as you have structured. What does perfect look like? Because it looks like maybe the government has an idea of what perfect should be, and maybe you can help enlighten us. We start with Liz, then Stephen. What's the background, and what do you envisage perfect looking at?
So thank you so much, Dr. Okaka. How I look at it is that, first of all, UHC is a journey. This journey was started a while ago. If you look at previously, a lot of interventions that have been put in place by government and even by the partners, both private sector and even development partners, to ensure that, and as I said, UHC is all about three things: accessing quality services, reaching the poor or the vulnerable, that means issues to do with equity, and financial protection. If you look since time immemorial, over the last even 20 years or so, there have been so many initiatives, which probably looking at it may seem obvious. For instance, if we say that we are covering, say, the HIV patients with ARVs, that is increasing access to those services to that population in need. We went ahead to do, supply, what we call supply side, looking at access to vaccines, access to family planning, commodities, TB, malaria, HIV medicines, looking at even maternity services, that's increasing access. And even when you look further, in terms of the equipment, access to equipment that was seen through the managed equipment services. All these have been efforts to increase access to all these services. And we can't say that we have not achieved. We have achieved in one way or another. Whether we achieved value, I would say maybe value for money, it could be questionable, but in terms of making progress towards UHC, we have actually made that progress. But then now the question we ask ourselves, do we want to keep on pumping in, say, inputs, whether it's for human resource, whether it's medicines, equipment, or do we want to be a little bit more strategic? So that we are not only just looking at, the inputs, but also we look at what is in it after we have invested in all this. And that's where the discussions around output financing come in. And basically that's where now the social health insurance approach has been adopted, so that we can first of all pay for a service that has been rendered. Of course, in the initial stages, it may be difficult to follow each and every output, but then at the end of the day, within this journey, we'll even what you asked me, what is this perfect situation, or what is this that I foresee would be a good approach? To me, at the end of the day, if we are able to even reimburse based on quality services, we bring in a quality metric so that we are actually accountable to the citizens, because quality will go hand in hand with even improved outcomes. Improved outcomes. So that's how I foresee it, that let us pay, let us purchase strategically, and at the end of the day, let us have the outcomes at the back of the mind. If we are meant to reduce, actually the question we should be asking ourselves, if we are meant to reduce mortality, even in, say, maternal mortality, from the 355 that we are at now, maybe to 250, what will it take? Then we work backwards and ask ourselves, what are those investments? How do you want to pay for these investments? Just as they say in the road sector, how it's done. They say for this kilometer of road, you'll need this amount. We don't ask how many workers will be there and all that. We just say, for this kilometer of road, we need this amount. And therefore, those are the questions we should be asking ourselves. If we are to increase life expectancy by 2 digits, what is this? What are the kind of investments we need? So that is an approach that I think, looking at the macro level, that we should really embrace.
Okay, thanks for that. Now you've brought the next question that then goes to Steve. Strategic purchasing, health outcomes, quality metrics. How are these demonstrated in the SHA framework as it is now? We have, the 3 funds you have shared. How do you expect to do it? What will it look like, Stephen?
Yeah, so in terms of looking at the legal process and the thinking behind that change in policy, the main idea we want to try and push for is we have one strategic purchaser for healthcare in Kenya. A big enough strategic purchaser where we can have, we can ensure that they are able to negotiate well with the healthcare providers, and they're able to ensure that their clients, not calling them patients now, I think their clients can be able to access the services that is of good quality. So one, we want to organize healthcare so that this big purchaser can, moving forward, which is the SHA, the Social Health Authority, it can have big enough numbers to negotiate. One, we ensure efficiency, and number two, they can also talk on behalf of their clients to ensure that there is quality of services. Previously, we have seen the NHIF, which was our, I would say, single largest purchaser in the country. It was only controlling about 7% or so of the purchasing of healthcare in Kenya. So we want to see if we increase that from 7%, funding going through and our single insurer, we move it maybe to around, let's say 20%, 30%, they will be large enough to negotiate very well for their clients. And they will also be strong enough to ensure that the clients get what they deserve. And that we foresee that it could translate, or it should translate to quality healthcare for all, or improved health services, in majorly ensuring that people can access that healthcare when they need it, not necessarily when they can afford it, but when they need it. Number two, we have large enough pool to ensure that when they are accessing healthcare system, they can subsidize each other. You know, like for example, in our own small communities, we do chamas, which is a very small form of insuring ourselves. So if we scaled it up to we scaled that up to around 60-70% of the population, and those who can afford are able to cross-subsidize the rest, we would be able to see some form of the healthcare outcomes improving, us experiencing some form of value for money, and generally having a more productive population. Another thing to look at it is in terms of figures, when you look at how we can monitor that. Currently, the healthcare system is very well, okay, we usually have that saying that the healthcare system doesn't have money, but that we usually mean the government healthcare system. But ideally, if you look at the entire health ecosystem, you're talking of controlling between 500 and 600 billion money going to health from various sources, from individuals, from national governments, from county governments, and from private insurers. No, that is a pretty large amount of it. It constitutes almost 5% of the GDP. But when you look at the other side, in terms of the national production of Kenya, you'll find that health contributes to only about 2.4% of the GDP. So there is a very big difference between what is being pumped into the healthcare system and how much the healthcare itself is contributing towards the GDP. So we would wish to see that that gap being narrowed. Either what we are investing goes down when we experience more efficiencies in terms of purchasing healthcare system, or most of it going into purchasing the actual healthcare services, so that we see an improvement in the contribution of healthcare system into the national production, or the GDP as you call it. So those would be the two main areas which I would look at it as an economist. Back to Dr.
Okay, thank you. Moses, you've heard about this push for healthcare outcomes, quality metrics, and looking at what the SHA benefit package that was proposed, looking across it, as a provider, do you see any specific push for outcomes, or do you simply see a menu that says, hey, this is what we will pay for, period, no discussions on quality? What's the feedback on your side?
Yeah. Providers are in this space mainly to provide quality and faith-based particularly. I can speak and vouch for them. But I've also been to private hospitals. I've actually even worked there. I think the fundamentals are the same. The doctor is waiting for the patient to provide the best quality under the circumstances. Is the government very keen on outcomes, or are they just giving us tariffs and a benefit package from where we are able to bill for the service that we offer? I think for the first time in many years, there has been more conversation really around tariffs and the benefits package. I know that the faith-based had a technical working group that was in the background trying to work out the tariffs and what they ought to look like. And we were, just listing all the ingredients that go into providing different services and then coming up with a total and then adding, the other overhead costs using some formulas and what we have seen other countries do. And we were a large team, maybe 25 different people from different hospitals providing service and so on. One thing we did is every time we did our costing, we came back to the providers generally, the private sector and the other stakeholders, and we shared what we were seeing and we got input and we improved it as we went along. I know that Dr. Elizabeth was instrumental. He actually kind of adopted us into the ministry team that was working on this, and we provided a lot of input there. They gave us a lot of feedback. Stephen Kaboro here is a very sharp economist. He gave us guidance, and we went and improved the tariffs a little bit. Where we needed to scale them down, we did that, and so on. So there was a lot of consultation, I would say. As to the final product, we still have, a few concerns. I can, for example, say that even though there was a general improvement on the surgical packages and the hospitals are going to be a little bit happier, than what we have done in the past, because perhaps there is the resource envelope has improved slightly. There are challenges around implants. And, we worked with a lot of surgeons from Kijabe, Kapsawar, and the other hospitals that do a lot of surgeries. And their concern is around the aspect of quality implants. It is a completely unfortunate situation where sometimes you have, a total knee replacement, but the implant that has been used breaks after some time, and then the patient has to go back and have a rework and that kind of thing. So we think there are areas that could be improved. There are areas around dialysis. We think the package could be improved a little bit. There are areas around maternity where, normal delivery has been around 10,000 for a long time, and CS has been around 30,000. There was a very slight improvement on those two aspects. They are key. We wanted them to be completely affordable. We want our mothers and our sisters to come to the hospital and deliver without any issues, without any barriers. But we also have to think about the person providing the quality and the hospitals and their sustainability. And we think these are areas for improvement. And we appreciate that we have to start somewhere. So even now, because, we have not finally done the national validation for the tariffs, we are hoping, because we have listed as FBOs about 21 areas where we think we can revisit. Let me just say as a parting shot that we think that the primary healthcare mechanism, the way it's currently being structured, has a level of complexity, because they talk about weighting the disease burdens and putting the money in a global kind of budget for the PCN, the primary care networks and so on. and then putting that money there, and that money being allocated to the different hospitals that provide that level of care, using some weighted means and stuff like that. I think even for a person who is in this space and who talks about this and who reads, I get lost in between there. So I'm thinking that, our small hospitals in the rural areas will have a difficult time understanding how this works and then following up on the payments. And when it becomes very difficult for them to either understand or follow up for the payments, they're just going to focus on the patient and say, you are sick. Can we find another way for us to provide service? Can you pay us, for example, and that kind of thing? So I would urge that the ministry considers very seriously looking at keeping this simple. Even the nurse in the rural areas is not a very complicated person, and they are not economists. And sometimes they do everything. So you want to provide something that is simple. I can tell you that the current capitation method, with all its challenges, is actually a very simple, on simplicity. I think it is light years ahead. I would urge that if there is an opportunity for us to look at that and see what is best. And if we are not completely ready on some of these aspects, we could actually start on the ones where we feel more comfortable and more ready and refine as we go. We don't have to get everything right the first time. What we must not do is create barriers for services from day one when we start on SHA. Thank you.
Thanks. Nice that you brought that up. I mean, those discussions on that, specifically the outpatient package, have probably been very convoluting, and we might not get the answers today, but then that's very good feedback back to government that if it doesn't make sense to healthcare providers, it will never make sense to the public. And evidence of this is purely, I can purely use this as a proxy. There's an article that's just been shared, how many people have registered for SHA. And government reports 465,000 people for the last 30 days have registered for SHA. I'm one of them, but I got blocked at some point. And maybe we'll also take a quick poll here of the 400 participants. How many have actually even begun the process of registering for SHA? That should tell you that the process is still not clear to everyone. The process could be out there, we could have heard of it, but maybe it's not as clear as it should be or as we imagine it should be. So now back to Liz. Knowing this, hearing the feedback from the FBOs, he's mentioned something, for example, on implants, and we can use that as a proxy for quality. You have stated you would pay for implants at this amount of money at this, and you have just that, and it's flat out that. Where does the HTA or the discussions on quality metrics come in? For example, with implants, do you have a way is that going to come later as another rule or regulation or another act that you'll slap us with? This government is very good at creating laws. But what do you envisage that to look like? And you can use implants, you can use diabetes. We don't know. All we have you will pay this amount for this product, and then you're telling us you're following up on quality. If I know you will pay 50,000 shillings for an implant, and I speak for everyone, my incentive is to pay, spend the least and make the most. So if I have two implants, one is 10 and one is 15,000, I'd pick the 10,000 shilling one. Of course, then the 40,000 shillings is mine. So how do you envisage that working and within the law as you have given so far?
Yeah, so thank you so much, and thanks Mukua for acknowledging that we really worked with you, and basically we worked with quite a number of stakeholders to come up with this package. A lot of lessons learned from the NHIF package, and even the provider behaviors, the patient behaviors, that really informed this current package. In addition to that, the law provides for the establishment of a health benefits and tariffs advisory panel, whose main role will be to look into all these things that are being discussed. Maybe something of note to mention is that one key thing that we don't have much of, believe it or not, as Kenya, is data. We may be collecting many things, but then when it comes to just narrowing down to the specific data that is required even to make some critical decisions, we are lacking. And therefore, sometimes we need to make decisions either based on what has been happening before, based on literature, and probably maybe it's literature of even countries around us, which will be largely scarce. I mean, Kenya, we are ahead of our neighbors, or probably now go to even more developed countries, of which now, when it comes to relatability, it becomes quite different. So in terms of, and you may realize that maybe something I would also want to touch on is that when making decisions on certain interventions, some considerations need to be made. Like, for instance, even if I just go to the implants, I know the implants, we had a very long discussion on the issue of the implants. And I know there's a team even from Kijabe who said, I think they were doing a study on the outcomes of patients following hip replacements with some of those what I would call quote unquote substandard implants. And it seemed that at the end of the day, in the long run, we actually will end up spending more, because these patients will probably need a repeat surgery, which at the end of the day to the health system would actually be an extra expense. And therefore, for that, some of the proposals we were making is that for some of those conditions that need permanent implants, then we can explore using, say, I would call the high-end implants, say like the titanium, either titanium, something that's more long-lasting. We are thinking of knee replacements, hip replacements, but then exploring other options when it comes to interventions, like maybe if you need an intramedullary nail that will, you won't really, probably, I've seen Dr. Okumu on the call, he may know best. Probably you may not need for, say, more than a year. So some of those are some critical decisions that you have to make, because remember, the envelope is limited, and therefore you have to weigh and ask yourself, what will be the best option? Because we know that even in some areas where resources are limited, some of these, say, other nails have been used and they have actually served the purpose. So those are some of the discussions that we were making, and we are really hoping that once this panel is, comes on board, such critical decisions have to be made. And therefore, the reason why this panel is meant to be anchored to a university, that is the reasoning behind anchoring such a panel to the university, because I know probably within the ministry and even social health authority, we may not have that capacity to do as much research as would be required. And therefore, through the university, we're even looking at options where, if we have critical decisions to be made, we can look for scholarships and actually send them to the universities and say that this is a need for the health sector, and list that if probably you want to get into this scholarship program, then this is the kind of topic that you will have to work on. For those who will be able, then that is the approach you're using. And therefore, what I'm trying to say is that the vision is there. You don't expect that come 1st of October, there'll be an on and off, maybe switch where you will say that now everything is all good and rosy. No, we will have to walk this journey with the foundations in place, with the systems in place, and of course get better. I hear you around the methods that are well known, and especially for primary healthcare, and really touching on capitation. remember, I vividly remember when capitation was first introduced into this country. And by then, people were saying, oh, how can you get this money? And yet when you see a patient, one outpatient visit is more than the money. It just needs a mind change. Over time, people accepted capitation as a method that works. Now we are saying if we are meant to go into output-based, even looking at justification for quality and outputs, because as capitation, I may receive the money and not offer the service, but you have received the money. But now we are saying that as you see the patients, we want to see the numbers, we want to see the diseases, and this is based on one big assumption that the digital system will be working. And we know that even within the country, not all facilities have a working digital system. And therefore, the whole idea that let us start off and learn our lessons, see, is it from us, when it comes to the side of quality, it's a good metrics, because then we are paying for the service based on the numbers. Basically, you have to offer that service to get the payment. So I think that's all I could talk about the different payment methods. It really needs a mind shift, and I know with time we will be there in that mind shift. For the facility in charge, maybe at a level 2, at a level 3, they don't need to know a lot of what's happening in the back end. What they need to know is that the numbers they are seeing, they'll be paid based on the numbers they are seeing, and different diseases, which probably they may be knowing. If you have a flu and this other person you are resuscitating for whatever, an asthmatic attack, you don't expect them to be the same. So all this will be in the back end. The only thing the provider will need to do is to do the usual recording that they usually do, even as they report.
Hello, is it? Hello.
Yes.
Yes, I hope it doesn't mind that got lost. So thanks again. Thanks for that. We are going to launch the poll shortly, just to get a feel of what the guys on the call have you registered for SHA. And just be honest, let's this is feedback for Liz and Stephen again, that this is a random subset of healthcare providers and their understanding of what SHAs and the steps they've taken, the calls to action that are there. So please start answering the poll. As I ask Stephen one question, then I'll hand over to Kazungu to the rest of the discussion. So Liz has spoken to a health benefits advisory panel. We know it's anchored in a university, and we have the list of people. So it looks like this is the dream team. They will set up all these HTA and quality metrics and all these things that we hope SHA will provide. Why hasn't it been set up yet? What are we waiting for? The legal aspects that have just fallen on the acts are very recent, and so there's been a lot of time to set it up. What has the delay been? And we've also spoken to it being anchored to a public university. We have just been very non-committal and saying public university. We understand the need for research. Is it going to be a specific university? Is that university going to change year on year? So what does that look like? Thank you.
Thank you, Dr. Okaka. For the first question, I think I will keep a bit because some powers, I think, rest more on the appointing authorities. However, I think the biggest step that we have right now is that we have provisioned for that benefits and tariff authority in the law. That is very key. It is very important in that in the future, we already have a pathway on how we are going to be working on the benefits, how we are going to be working on the tariff. Now, in terms of the current benefits and tariffs that you are setting for the initial start, you remember what Dr. Wangi has said, that we have a lot of data, but currently we have not had a way of collating this data so that we can make any tangible information out of it. So before this benefits and tariff authority comes on board and starts working, we will have to have a digital ecosystem which can actually collect all this data from as many healthcare providers, from as many individuals, and from as many community health workers as possible, and be able to collect in a central database. So that is what currently is being set up. We foresee that before the next benefits and tariffs are considered, we foresee the initial one might be done a bit faster especially once we see how the response rate is from the population. We see how the amount of receipts and premiums that the SHA will be receiving. We'll be able to make more informed decisions on how to improve the benefit package, as Dr. Mokua was requesting. With that, by then now we will need this team to be sitting and be able to advise the SHA board and the ministry going forward. So I would say I would not have any conclusive idea on why it has not been set up, because the appointing authority has more information or more say on that. But to note is that currently we don't have enough infrastructure, enough information for them to start crunching the numbers. Now, where are they going to be set up? This will be an independent authority, the Benefits and Tariff Authority. We know that they are going to have a chair who will be appointed from the academia. Now, when we say the chair is appointed from the academia, we do not mean it is one single university. That authority, it would be like a commission list. So that authority will have an academia chairing it. It will be responding or answering to the ministry and the SHA board and advising the two organizations in terms of setting and agreeing on the benefits and tariffs. The third point to note is that the secretariat and other officials, the information that will come, that's where the collaboration will come between the authority and the university. So I would not want to say university. So it is universities at the moment. The data, however it will be hosted, I think that's a decision that will be made going forward. But the collaboration between the academia, and why we have the chair being from the academia, is that we ensure that there is that collaboration between all the learning institutions in the country who can be able to provide, once they have access to this data, they can be able to crunch the data and give us information which can be used to make decisions with. I think with that, I take back the mic back to you.
Thank you very much, Stephen, and all the speakers before. I will take over from Okaka for the next few, just to continue this very candid conversation and just highlight some of the questions that are coming through, especially from participants. And just maybe to start with you, Dr. Wangi, one of the key things that has been bedeviling the NHIF specifically, it has been, issues around, fraud, poor accountability, perhaps issues around lack of adequate transparency, and providers have not been fully able to hold, for example, NHIF accountable when there are delays in payments. I'm just wondering, and participants are asking, how is it going to be different under SHA as we move away from, or as we have moved away from NHIF?
Yeah, so thank you, Kazungu, for that question. And indeed, it's a question that not only providers have been asking, but even friends, when you meet people, they ask, how sure are we that this 2.75% will be utilized well? I would like to say that one, issues of fraud, let me start by mentioning about issues of fraud, could be right from, well, let me not say start, could be from the patient or the patient. The second aspect of fraud could be from the provider. This health, the doctors that we have, my colleagues have been unfortunately part of the fraud issues. Number three, it could be probably still within, of course, the system itself. So, and I know that many times we focus on the fraud within the system, but we know that even us as a patient, when I give my sister my card because she doesn't have a card, and I tell her go and seek service and claim your me, then that is actually fraud, because it denies the fund the resources probably that they would have made from this, from my sister, for instance, had she been a contributor. Doctors have claimed to do certain procedures when indeed they have not done those procedures. And maybe some, for one reason or the other, whatever reason they have. And I'm not saying that probably, I'm not accusing those who do cesarean sections or deliveries that that they are the ones on the spot. But I can assure you, when I saw a report indicating that the country now has high cesarean section rates, probably it could still be true, but also the reason, basically the fact that a cesarean section pays higher than a normal delivery. Someone conducts a normal delivery, but they claim for a cesarean section, and therefore they have to carry that lie all through. That means even as they are doing their final reports on DHIS, they have to write that they did a cesarean section. And therefore, all these are reasons for fraud. Now, coming back to the system, part of the reason why we had to move from NHIF to SHA is, number one, just starting from accreditation, because the accreditation process is the entry process for any form of fraud. If an organization comes and accredits a facility, has the power to do the accreditation of the facility, and I claim that your facility has 50 beds, when in essence it has 10 beds, that means this facility can daily be churning 50 patients, whether they are real patients or not, or fake patients. But at that point of that accreditation, I don't know whether the impact of their action is really well known to them, because you may just be thinking, oh, let me do this and just say I have 50 beds or I have 3 theaters. But then the impact of that is that over time, you'll keep on claiming that you have seen all these patients. And we know, and that's why I said even some of our colleagues are part of all this. You actually sit down and formulate records and say, you actually have a whole story of a patient for a week. You know, that is just wrong. So looking at that, that's why we say this accreditation process has to be independent. And therefore, we left the accreditation to the relevant bodies. If you are a pharmacy, because we are really hoping that we'll, in the course of these first 2 years, we'll also accredit even standalone pharmacies. Then let the Pharmacy and Poisons Board do their work. They tell us these are the pharmacies that we know are accredited, and therefore they'll be held by their acts. Because if you claim that they are not accredited and it's within your act to say that this is this pharmacy can offer this service, the same will happen to health facilities. If KMPDC, for instance, accredits a facility and says this is at this level of facility, it has this number of beds. At what point, if you start churning 50 patients and you had 10 beds, then it will be easier to come back to these specific facilities and ask, how is it? What magic are you doing? Are patients sharing beds? And if they're sharing beds, that means quality is poor. So it all starts with that accreditation process. Moving swiftly to the benefits package. As you can see here, the benefits package is independent and it will be based, there is a whole panel that is not just government. It has representation even from the civil society who will sit and say, based on the data, this is where we are going. And therefore the issue will become more accountable. Because also the benefit package could be one, it's been known even from other countries that it's one area in which a lot of fraud takes place, because you may just lobby and say, okay, let us put this within the benefit package, and someone knows that once this intervention is within the benefit package, they're happy for the rest of their life. And therefore, that's why this process had to be independent. The third main area that we brought in, actually the third, and I'll have 4 main points. The third main area is around dispute resolution, because if you look at how NHIF used to operate, is that they were still the same ones who could handle the disputes. But now we are saying, for the sake of accountability, if someone has a dispute of whatever nature, this one will be handled by the dispute tribunal, so that at least there is an independent body that can actually go and do the independent investigations and actually find out if this is actually the case. And the last area is around digitization, because with digitization, it becomes very quick to even notice any anomaly. If, for instance, you have been seeing this number of patients, then all of a sudden you have a spike. Either you have a reason that could be justifiable, maybe you have expanded your facility or something like that, but then spikes don't just happen. It has to be gradual. So the whole issue of digitization has also come a long way to ensure that this, at least the issues of fraud are coming down. And also with the same digitization, because I know we have been also working on digitizing the benefit package, because that will have to go hand in hand with the claims. And I saw a question around the claims. How will the claims processing go on with the 3 funds? If you look at each and every package, we have identified each package, mapped the ICD codes that for the condition. If you look at the package, most of them are based on interventions, not necessarily diseases. So like, for instance, if I say a laparotomy, that will reimburse laparotomy, we can have all these conditions that could possibly fall into laparotomy. So if you bring in another condition that of whose indication is not laparotomy, of course that will be immediately rejected. So some of these things you have put, systems you have put in place, will actually help us identify some of these issues early enough. If I've done already amputation of one leg or whatever below knee or something, I can't again claim to have another amputation below knee. So within the digital system, since the SHA is actually feeding into the greater digital, what we call digital superhighway, where there'll be patient-specific records with all those conditions. And this, with all this in place, we are seeing that somehow it will help reduce fraud. And I cannot say it will eliminate fraud, but at least it will reduce. And if there are any changes, if, you know, people, first of all, Kenyans are well known to be innovative. They'll always try to beat the system. As they try to beat the system, then you get better. So for me, at least from our end, the structures are in place to kick us off. Ours is now to see, once we start once the providers start offering the services, what are the behaviors that we'll see in place, and learn from that, and that will inform the next round of the benefit package.
Thank you very much for those 4 key points around accreditation, benefit package, you know, formation of the dispute resolution, to handle some of these disputes, and digitization. So I'll start with Kaboro in the next 2 questions, and just trying to summarize most of the questions that are coming up in the Q&A. And there seems to be quite a lot of interest around the quality of care, you know, and incentivizing providers to deliver on quality of care. As I start with you, Kaboro, there were discussions around the Kenya quality model for health and star rating facilities. How is that maybe incorporated into the SHA conversation around also payment methods that would incentivize healthcare providers to deliver on better quality? And as I come to you, Moses, what's your thoughts as providers around, star rating system to be used as a mechanism to incentivize healthcare providers on aspects of quality of care?
Thank you, Jacob. So I would like, first of all, to tackle the issue of quality from a different perspective before I come to the issue of star rating. This is, and I know you are an institute economist, you are aware of this. There's two ways you can ensure quality in any services that are offered, whether private or public. Number one is to force the institutions that are giving goods and services, you force them to offer quality. That is one way you can enforce quality. The second way you can enforce quality is to incentivize the creators of goods and services to create quality goods and services, or to offer quality goods and services. So incentivize. So I would initially think, and as Dr. Mukua was saying, we cannot start with a perfect system. We cannot start with a perfect healthcare system. So the healthcare system, from where we are starting from, it is the base, which we have to continue improving as we proceed. And I try to look at the issue of quality in the area of incentivizing healthcare providers to give quality service. Now, how can we incentivize healthcare providers? We know about the more than half of the healthcare infrastructure, and especially for the marginalized areas, is controlled by the government, either county government or the national government. The system which Dr. Wange had described for this more than half of our infrastructure, it has not been, it has no incentive for quality. It has more of input-based service provision. So from one of the projects that we actually did as Ministry of Health, the precursor to the Linda Mama, it was called the OBA vouchers. I'm sure most of you went through it. So we tried to pilot a way of incentivizing facilities to offer quality service without having to whip them. How do you do that? You ensure the power to allocate money to a facility sits with the individual who wants this service. So you know that in economics, an individual has more information about quality. Even when you talk about healthcare systems or healthcare services, which we know there is information asymmetry, yes, but individuals will always more or less have an idea of quality. Where is the best quality? And give an example of the coil Dr. Mukua was talking about. The coil, okay, I don't know the medical term, I'm not a medic, but that coil that you have to keep on replacing. That person who has to be replaced a coil, they live in the community. They will go and give feedback to the community that such and such a facility, you go there, either you'll get a complication, you'll be done a CS which is not necessary, or the coil will come out after 3 months. So if the community gets that information. Now, how does the community react to that information? They will go to the facility where they have good feedback from the facility. Now, what does that do to the money? The money follows the patient. So this is what you're calling output-based financing. So this money will start following these patients. And the facilities, we also learn we have to offer a better service for us to get more money. So that incentivizes the facility to offer quality. So that is one key aspect which, through financing, we can actually improve quality. Now, there's the second aspect of star rating. This has been there as a discussion, I think, since around 2015 or thereabouts. It has been piloted. It's something which has been in the discussion, the SHA board. And I remember at one point when we were making the legal provisions, there was a discussion where whether we should actually have those clauses on star rating of health facilities. But I think at some point, as Dr. Mukua was also saying, we don't want, this is a reform which is going to take time. It will not happen overnight. So these are improvements we have to continue having, we have to continue improving on, and at one point, we have to ensure that it comes and becomes part and parcel of the healthcare reimbursement mechanism. So the discussion is still there, still very much alive, and we hope it will work in the future. So that will actually be what I was calling whipping the facilities to offer quality service. So we first of all look at incentivizing the facilities so that the actual intention to offer quality comes from them, and the actual monitoring of this quality care. The actual monitoring happens by the community themselves. The community have more information than any information that the Ministry of Health or the SHA board or the Healthcare Federation can actually craft in a board. Back to you, Dr. Kazungu.
Thank you very much for that, Stephen. Over to you, Moses.
Thank you very much. So I agree 100% with Mr. Kaboro there, that star rating will be the future. That is where we will be going in order to address the issues of quality and to incentivize the hospitals that are doing a good job. But allow me to make a couple of other comments. The digital superhighway is an excellent idea. I think, you know, if we get it right, it will sort a lot of issues. Patients will not have to carry files from one place to another. You know, whatever has been done previously doesn't have to be repeated in the next hospital and so on. Now, from the provider's perspective, if we are starting on October 1st, my rural facility for the faith-based should have that computer on that first day. It will need to have internet on that first day. I need to have a biometric reader on that day. I need that nurse who is also the clerk and the customer care person and the community mobilizer. I need that person to have been trained, not once, but perhaps trained and having a pilot kind of system going through their hands and making mistakes and learning from them so that they are ready to use the technology. We must assure that that person will have power, Kenya Power or a generator to run their system and so on. I talked about internet. If these basic things are not in place, it will not just be my faith-based facility that will have a problem, serious problem in giving service. It will be government, it will be a lot of the private facilities in the rural areas and in those very underserved places. So I think one of the challenges that I see is that we have run out of the transition period. You know, the Act gave us 12 months. We are going towards October and November. And beyond that, there might be a problem if that system is not ready. And I want to connect this with what Dr. Dennis Okaka was talking about, that he was blocked by the system in the process of registration. The SHA website where people are registering, I'm actually very impressed by those who have navigated through the blockages and the barriers and been able to finally register. But Dr. Okaka said that he was blocked. I can almost tell him that he's not among the list of the people that are fully registered. I think Dr. Okaka, you need to go back and check. Most likely he did not finish the process. So technology is not a straightforward thing. You need like to click the right place and you know, proceed to the next stage until you finalize and submit your documents. I think we need to be sure that it is friendly, it is simple to use. It is not high-tech people that are going to register. It is the rural ordinary folk It is my mom and my dad in the village, and they need to navigate it. Let me say something, because I represent providers, about payments. There's a lot of money that providers have given service and is still being held under the NHIF system. There was another time when another transition happened. This time it was just a system transition, and claims of providers were archived. They are still in that archive. There is a rational, real, practical apprehension, I would say, that during this transition, hospitals might lose their claims. I would appeal, because I know that Dr. Wangia and Mr. Stephen speak to their bosses, both in the ministry and at SHA, that the hospitals are appealing that this additional 3 months that we have, there is an effort, very targeted, helping the new CS when she gets to the office, to ask the government to provide the funds from Linda Mama and the other government-sponsored schemes, and pay the providers for the services given as we transition. And if that is not done, whatever business SHA begins with prioritizes clearing the past, so that all of us can then move forward together. So if we don't have so much money in the system, we have national debt and all that, whatever little shilling that is available should be used for service delivery. I'm saying this deliberately because of the claims office, which we understand for some good reason is going to be outsourced to somebody else and so on. We don't have the money for that kind of luxury right now. I would say that every small shilling that is available is used in service delivery, in paying the providers that are providing the service. Finally, the superhighway is supposed to help us detect, prevent, follow up fraud and cheating. And I think because there are a lot of providers listening to this call, I want us to socialize ourselves to actually lead the fight and support the government and SHA to prevent to prevent fraud. We can report bad manners. The system should be able to flag out the bad manners. And the government system should also be quick and punitive. We would be happy to support that system as faith-based. And I wanted to offer, so there's some faith-based hospitals have been here for 100 years. They have done clean business without cheating, and they have been sustainable. So it is possible to be sustainable without cheating, and we can adopt that. But let us drop people with bad manners. Let us make it painful for them, so that the good ones are allowed to proceed and to continue to give services. But the superhighway is going to play a critical role in flagging, so the government can move in quickly and check what is wrong. And thanks for the opportunity, Jacob.
Thank you very much, Moses. I think I'll pick from your last point around, the former point around, every shilling must count in provision of services. And maybe to come back to you, Wangia, on this, we've had these new funds, especially the tax-funded funds, how we had budgeted for quite considerable amount, but the proposed allocation that has been given to the funds perhaps is much lower than what we had envisioned. So the general question around this is, yes, I agree that, we need to start from somewhere, and we can't start from perfect, but what are some of the mechanisms that SHA might put in place to ensure that funds, especially for these funds that are appropriated by the parliament, are ring-fenced, and we don't have, when we have budget cuts, then those become the low-hanging fruits for cuts, and therefore limit access to services for the population?
Yeah, so indeed, that's a good question and something of concern. It's been raised by quite a number of people, and knowing very well, based on our engagements on what, say, the PHC fund budget expectations, or what I would say the cost of the PHC fund and the emergency fund vis-a-vis what was appropriate, what was budgeted for. I would want to say that first, that as we start offering the services, there is the expectation that not everyone will register all at the same time. Come what may, even if we do mass registration, we won't reach the 50 million Kenyans at the same time. And even if we reach them, there is the natural tendency of how diseases behave and how people access services. So even when it comes to accessing services, we also don't expect that so long as you are registered. I know there's also usually the hype that when there's something new, you want to try and see really how is it. But then that at the end of the day, that will soon stabilize. So for us, it's a plus that one, we didn't have a budget line called PHC fund, and we got that. So we got that. And to be very specific, I mean, it's very well known for the 4 billion, and we know what we asked for, and we were told, let us start with this as we progress. The other discussions we have had, which are very technical discussions, is that yes, there are these services within the package, but we don't have to roll out everything at the same time. And the reason for not rolling out everything at the same time could also be technical. Like, for instance, there was a component of pharmacy package within the PHC fund, but as we speak, we don't have those clear structures to onboard all forms of pharmacies yet. This is something that is being worked on. So some of those packages, we see them being implemented at month 6, month 3, month 6, and others starting month 12. And I don't think there's any issue with that, so long as for us, we are saying this is what is realistic, and therefore these are the services. Yes, this is the benefit package as we speak for the next 2 years, but then we'll roll out some of those packages in phases. And that is the reality, because we must all admit we are all in Kenya, and we know the challenge that we have had macroeconomically, and therefore we need to adopt. We can't just be rigid and say we promise this big spade, and therefore we need to give that the whole spade. We can start with big spoons gradually until we get to fill the spade. Yeah.
Okay, thank you for that. I know we have kept the teams, beyond the time we expected. What I will ask is this: there are quite a number of questions that I see are still being put in the chat. Please transfer any questions you have. Hello? You haven't lost me, okay. Please transfer any questions you have to the Q&A tab. The reason is this: we are able to follow up specifically with each question to either Liz or Stephen, because then this also form part of the continuous feedback we give to the Ministry of Health on what providers are saying. So even if we haven't addressed the question here, so long as we have a record of the question, we have a team that's looking through. And if you understand Zoom, you get the breakdown of each question. We will be able to share these questions and follow each of these questions up with the ministry after this webinar. So please don't give up. We are unable, of course, to ask all questions, but we will ensure we follow each and every one of them. We are as interested as anyone else could be. Then I don't know, Martin, are you able to put up the poll? Had you put up the poll results? This is just as feedback to the Ministry of Health to show them registration among providers. Martin, are you able to put it up to project the results? Hello, Martin?
Please come again, I lost you.
No, I was saying, are you able to project the poll results? I just want,
Yeah, sure.
yeah, direct
Please
feedback to.
confirm you can see my screen.
Yes, yes, you can.
So we are yet to end the poll, but so far we have 316 out of the 349, which is 90% of.
We can't see the actual results. We see your desktop.
Let me see.
Yeah, we see your desktop now.
What about now?
We still don't see the results. We just see your desktop.
I think Martin just end the poll and project the results.
Yeah. There should be an option of projecting the results. Yes, exactly. So this is just as feedback. Yes, we see it. I think everyone should have this on their side. So 75% of attendees have not registered for SHA, and that tells you something. I mean, there's still more that needs to be done. That's the challenge you're sending to the team at Afya House. What we will ask is, where do you think we can help? So that then, again, we are healthcare stakeholders. We are probably the ones who will also be involved in registering the rest, even if they will still come to us. And as far as I can tell, I don't think we have any private healthcare providers involved in registration. Maybe that's something you need to include. 52% of facilities are private anyway. So because of time, I want to close the webinar, but I want to check if Dr. Theory is on the call and is able to give us a final closing remark.
Yes, I am.
Okay.
Yeah, Dennis, I am. Thank you, Dennis, Kazungu, panelist for the evening. I'd like to pass my sincere appreciation on behalf of my board, represented here by Dr. Vinod and Jakudul. And at this point, I'd like to request them, maybe in 30 seconds, to each say hello to the attendees. Jakudul first, then Vinod.
Hello, everyone. It's been a good session, just tackling the issue of SHA. I was more into how do we ensure that as much as we're trying to do the UHC thing, the quality aspects of care, because by the end of the day, you can be able to ensure that quality aspect is taken care of through other means. We have the KQMH that needs to get to the level whereby most hospitals should be able to adopt it, other than only the government hospitals. I think there are other accreditation standards like GCIA and also the SafeCare and the COSAS and many others. So as we look toward getting this into place, we should also now emphasize on the quality of care, as much as we're saying that we need to start at the basic level. But the quality of care is also quite important, and that's why most of the guys go to the private facilities. Otherwise, it's been a good session, and I want to thank you for organizing this theory and team.
Thank you, Jakudul. Dr. Vinod.
Thank you, Dr. Theory. It's been a very good session. In fact, quite insightful. Quite a few topics have been touched on, and I must say that we have excellent panelists on the call. They've been able to address quite a few issues. But in my opinion, I think we should have kind of a FAQs, because the kind of question that were asked on the chat box and even on the general chat, we could probably collate all this together and put forth a FAQ so that people are well aware. And maybe Tim, as KHF, we should start rolling out information flow into the general public so that there is no uncertainty or there is no skeptical view of how people are kind of looking at this the new funding mechanism for health. Having said that, well done, and thank you to the panelists on behalf of the Board of Directors of Kenya Healthcare Federation. I'm not saying I'm not giving a vote of thanks, but I'm saying thank you. It has been a very informative session. Thank you, Dennis, and the team for so well moderating the sessions. Over to you, Tim.
Thank you so much, Dr. Gakombe, our chairman, and our vice chairman, Dr. Elizabeth Wala, pass their kind regards. They would have wished to be here with us. However, they ask that you receive their regards in their absence. I'd like also to recognize Njoki Fernandez, the chair of the Healthcare Financing Committee. Thank you for being in attendance, and of course, Dennis, our vice chair in the Healthcare Financing Committee. This conversation, we promise, will keep going. We will upload this particular webinar on our website for ease of reference, so that we are all able to refer to it and ask others to listen in. From our end, tunasema ni asante. KHF continues to lead the provider engagement with SHA, and so far we've been received positively, and we are working collaboratively together to see that this becomes a success. Where they call upon us to be a bit patient, we will, but we promise to keep on to keep the feedback coming in so that the market responses are adequately addressed. So asanteni sana, Dennis, over to you, and thanks to my team who made this a success.
Thank you again. There's nothing more once your boss has spoken, Bwana CEO. So thanks again. As a Healthcare Financing Committee, we have taken your feedback, and thank you, Dr. Vinod. We'll put in the, create an FAQ, something that we can also be sharing with the public, and see how we can see SHA to its success. Thank you to the Ministry of Health, Liz and Stephen. Thank you, Mokwa, for your insights. We wish you a great evening to the rest of the people on the call, and let us meet next time.
Thank you.